Okay, so unfortunately, we certainly know nowadays that this is a site that can frequently become infected. So while I'm going through this, hopefully you are pausing the video and reminding yourself about the stages of the inflammatory process and then its crossover to adaptive immunity. So let's say here's where our infection is going to take place. Because the thing about respiratory infections is they can be viral, bacterial, or fungal, or all kinds of infections, and the manifestations of that infection are dependent on the agent, the person's immune status, and the features of the immune inflammatory processes being applied to this area. So we have our innate and adaptive immunity. The innate immunity is made up of our barriers. And then if the barrier is breached, we begin the inflammatory process. So our barrier was our mucociliary elevator, which had those squamous cells that are close together, that have the villi on them, the goblet cells that produce mucus to kind of coat this area, which should hopefully engulf any bacteria, viruses, and coughing will help escalate and get that um, stuff out before it even has a chance to cross the barrier and cause an infection. So, okay, the infection got through the barrier. That is a type of tissue injury which causes the inflammatory process. So that we remember has the vascular phase and the cellular phase. The key symptoms or key issues or things that happen during the vascular phase are vasodilation with an increased redness, usually, and heat to the area, as well as exudate, the beginning formation of exudate and edema because of the leakage of capillaries. So hopefully now you're pausing so you can write down all those steps because you're going to be able to say them and write them out before I say them to you. So pause and write it. Okay, so you've unpaused it. You didn't just pretend. That means that I'll give you the mom look. I hope you didn't just pretend. You know how important this is to me, and I can't get to see you to tell you in person. That during the vascular phase of inflammation, the complement cascade is activated because of direct tissue injury to the cell membrane. The arachidonic acid is released, which means we begin the production of prostaglandins through the coxagenase enzymes, the COX-1 and COX-2 enzymes. So we get our prostaglandins. And any injury or degranulation of mast cells will release leukotrienes and histamine, which will cause vasodilation as well. So there is our redness and heat because of vasodilation. Once the other activity of histamine, which contributes to edema and to the beginning and early production of exudate, is contraction of endothelial cells, increasing the size of the capillary pores, which allows fluid and protein to leave the capillary space, and that protein that's left increases tissue oncotic pressure, which will pull more fluid into this space. So the early phase of inflammation should be red, hot, swollen, clear, potential exudate. The second part of inflammation, so now you're going to pause again because you're going to write it down because remember there's the 4 processes and you have to get a chance to write it down, so you're pausing. Okay, so you've unpaused because you wrote them all down. The cellular phase is now that those pores are open, is margination, transmigration, chemotaxis, and phagocytosis. That's the cellular phase of inflammation. So we pulled neutrophils from the central part of the blood circulation down, sticking with integrin selectin to the endothelial cells. Those pores are open, so those neutrophils can transmigrate and go into the tissue space. where all those proteins are, and they themselves will cause chemotaxis, increase neutrophils to the site. They will also send a colony-stimulating factor to the bone marrow to increase production of immature neutrophils, which is what drives that shift to the left and an increase in our white blood cell count. They will begin the process of phagocytosis, where they will engulf bacteria, pieces of cellular debris, etc. It'll interact with the lysosomes and break down, and then the neutrophils do not divide, but rather open, spilling their contents, contributing to exudate either being hemorrhagic versus purulent, and as time goes on, it becomes more fibrous, and hopefully, as the macrophages come in, if we don't have to worry about infection, that would be when we would start healing. But sometimes that doesn't occur, especially in the setting of infection, and the production of exudate and the macrophages get us to the next phase, getting our third line of defense, the adaptive immune response. So now you can pause it again, because you're going to write down what the adaptive response is. So now you've unpaused it because you remembered that the exudate drains through lymph channels into lymph nodes, where any infectious material can be presented to immature B lymphocytes, or the macrophages, dendritic cells, natural killers, different antigen presenting cells, macrophages, dendritic cells, antigen presenting cells can show this information to a T helper cell, so we can find the specific mature antigen. We can select the correct clone. That B lymphocyte can become the mature B lymphocyte by differentiation that responds to and creates the plasma cells and antibodies for a particular infection, or can be presented to a cytotoxic T cell that differentiates and becomes the cytotoxic T cell that's specific for a particular viral infection. So we know for bacterial infections, at the end of adaptive immunity, we should end up with antibodies and cytotoxic T cells. At the end of a viral infection, we should end up with both as well, but the issue is the B lymphocytes and the antibodies are much better at bacterial infections, although they do help with viral infections as well. The cytotoxic T cells are much better at handling viral infections, but that's the end line of the adaptive immune response. So if the manifestations of the infection takes place on the conducting airways, then it's named really for the causative agent and which portion of the conductive airways are affected. So pharyngitis, back of the throat, laryngitis, the vocal cords, laryngotrachobronchitis, which is croup, or that first, the larynx trachea section, epiglottitis, that skin flap can get infected, bronchitis if it's the lung tubes themselves. But if we're talking about infections of the conducting airways, then we're not talking about infections of the lobules. It's just the passages. But that's still bad. I mean, obviously, if there's an infection in the lobule, then we affect diffusion of gases. However, if we have okay, so, but they're still important. Obviously, they're very uncomfortable, but if we change or if we cause an infection or inflammation in the conducting airway, then we decrease the amount of flow that can get to the lung lobules. So it's always bad, just different in how the infection presents. So if I get an infection, so a microbe has breached the protective layers, the barriers, and has triggered the inflammatory process, then I will have inflammation, which will cause turbulence of air, which decreases flow. That inflammation will change the ability, does not allow for laminar flow. And in that area where the inflammation or mucus production has taken place, I will have a decrease in size of the conducting airway, a decrease in radius, which increases resistance, which also decreases the amount of flow. So depending on how severe this is, the person could still have decreased oxygen or hypoxia if we're not allowing enough air to get down to the lobules themselves. Also, the more this gets inflamed, there's the possibility of complete obstruction. And there's the mucus production and the discomfort and fever and all the other associated signs of infection. So that first picture, which looks like to be slide 21, is an x-ray of someone with laryngotracheal bronchitis, which is croup, essentially, which is inflammation in that larynx trachea area, which on that x-ray you can see that's called the steeple sign, where this has come in so far from inflammation of the radius that it's hard to get air down into the lungs themselves. Epiglottitis, that's inflammation and infection of the skin flap that covers the larynx while you're swallowing so that food doesn't go down into the lungs. So that gets infected, it could completely obstruct air going down past the larynx into the lungs. That is frequently, laryngotracheal bronchitis or croup is a viral infection that kind of comes in seasons. Epiglottitis is usually a bacterial infection. A side note for you, that's how George Washington died, and he actually took him a couple days to die. He did have antibiotics available to him, but decided that he was too strong, he didn't need them, and so he ended up suffocating to death in his 60s. He didn't even get to enjoy his retirement, so that's a little trivia for you. So that's how these types of conducting airway infections can affect you. If you had bronchitis, you don't have infection of the lung lobules, that's the lung parenchyma or the alveoli. You have an infection that's obstructing the airway, just the smaller airway. So it just depends on where it's located. So sorry, my dog was barking. But the bronchitis infection is an inflammation of the smaller tubes. Again, we're decreasing the amount of airflow that can get to the lung lobules. So at this point, if we were all together, most of these infections of these conducting airways in adults are viral infections. And so this is when I would have you raise your hand and solemnly swear that you would never ask your healthcare provider for antibiotics when you get a viral bronchitis, because most adults without secondary lung issues would not need antibiotics for bronchitis. So you should never, ever, ever ask your primary provider for either a Z-Pak for sinusitis, because that's not really the right treatment anyways, or a Z-Pak for bronchitis because it's probably a virus. So you should solemnly swear that at this time. Hopefully you're doing that. I'll have to ask FBI agent monitoring your computer later if you did. So what is important to note is that infection that occurs in the conducting airways can impact the ability to exchange oxygen, but not because of a direct impact on diffusion itself. It's because we can never get anything there to begin with. If we can't get air down to the alveoli, then we can't have gas exchange, which is different than an infection that's affecting the lung lobule, which is the lung parenchyma, the stroma supporting lung tissue, and the alveoli itself. And that is a pneumonia. So factors facilitating the development of pneumonia would be the type of organism and how strong it is, how large the exposure was, if the patient is immunocompromised. These agents are classified depending on what it caused it, where the person obtained the infection, and how it's distributed in the lungs themselves. So that infection can be community or hospital acquired. The community acquired means it was not in the hospital long-term care facility. It could be hospital acquired, or lobular means that when you look at the x-ray or you see the infection, it's in this alveoli in one section of these lung lobules. Or bronchopneumonia means it's several sections. So it's a more severe type of pneumonia. So now the organism has made its way all the way down to this area. So there is no inflammation of the lung tubes with the pneumonia. So sometimes people are like, well, it's obstruction. No, this is a problem in the area where diffusion takes place. It's the lung lobule that's infected this time. So the organism reached the squamous tissue here, causing, again, the same stuff, the stages of congestion. So if you look at slide 24, this is how people sometimes describe typical bacterial pneumonias, including what happens this happens because of the vascular and cellular phases of inflammation and the adaptive immune system. So you'll see first it says stage of congestion. So because of the vascular phase, there will be vasodilation and the first beginning of exudate. And that's when there might be starting to be an increase in swelling and fluid collection here. Then we get to what in pneumonia is called the stage of red hepatization. And what that means is we've reached the cellular phase. Now we are developing the more purulent exudate. We've got the neutrophils there. There's lots of congestion, so there's an increase in fluid. We call it the red hepatization because if you actually looked at it looked at lung tissue on someone that had postmortem, it would be very hyperemic red and full of fluid. As time goes on and we're starting to clean up the area after infection, hopefully the adaptive response is underway, or we've got medication and we're feeling better, we get what's called the stages of gray hepatization. So that's the end of the inflammatory process where you see more of the fibrous tissue, then the healing phase, and then it resolves. So the usual inflammatory processes, vascular and cellular phase, are transposed onto the lung lobule. So the other common respiratory infection that we talk about is influenza. And influenza is a viral infection that we get immunized for, which can't cause influenza because the virus is synthetically engineered in that influenza vaccine is genetically engineered close enough to influenza, but not enough to infect you. So you might feel sick after the influenza vaccine, but that's just because it's revved up your immune system as you create antibodies and cytotoxic T cells for memory. So every year, the influenza virus changes slightly, and that is called the antigenetic drift, which are changes in its protein structures, its main proteins, surface glycoproteins, which allow entry and exit from your cell, the HA and NA proteins. So what happens is there's about 3 different types of influenza, A, B, and C. These types of influenza can have mutations of their HA-NA proteins, especially influenza A. And that explains why you can never just get a flu shot and then have it take care of every single strain of flu, because the flu virus itself is constantly mutating. There can be crossover, so I could have gotten a flu immunization that's not completely correct, but it's close that at least my symptoms are decreased, or I might have a decreased length of symptoms. And that explains why sometimes there can be major genetic rearrangements, which is called an antigenetic shift. That means that the influenza virus is much, much different than it was before, so there's no cross immunity from previous strains, and that's when there tends to be a pandemic, which is our last influenza pandemic was in 1918. So a person gets inhales the viral particles. It's a virus, so it's an intracellular parasite. It cannot grow on its own. It'll attach to your squamous epithelial cells, your conducting airways, go inside your cell and use it for replication, and then come out of that cell in order to infect other cells so that it can replicate. It's doing that can injure those cells, causing holes in the cells, which is why people with influenza tend to have a lot of mucus production. What it is this hole in the squamous epithelial cell and that basement membrane will then cause tissue fluid to leak out into the conducting airways. And so people with influenza tend to have a lot of congestion. That's just fluid leaking from that area. So the person will be infected with influenza. There's a 1 to 2 day incubation period in which they could potentially cause viral transmission, but they don't have symptoms. Then they'll have symptoms, and then it'll go away, but there's still 3 weeks when they will shed virus and potentially share that infection with other people. So influenza can have 3 types of presentations. Rhinotracheitis, which is upper respiratory infection, which is sometimes hard to distinguish from the common cold, except that there's usually huge, rapid onset, a higher fever, and much more mucus production than would be common of a common cold. It could end up infecting the lung lobules if these secretions were aspirated or if the infection got further down the conducting tree, causing a viral pneumonia. Or it can weaken the barrier with this cell destruction. It's much easier to get a secondary bacterial infection. So pneumonia is the 8th leading cause of death for adults. Influenza can be 7th or 8th leading cause of death as well, depending on the year. And of course, I would be remiss not to mention our current issue, which is COVID-19. So COVID-19 is a new novel coronavirus, and coronavirus is one of the virus families that are responsible for common cold, like rhinoviruses, adenoviruses, RSV. There's all types of families of viruses that mutate, so we don't always, we can get exposed to a slightly different one, so we can get the infection next year. We don't always retain our immunity to these viruses over several years, so we got the coronavirus that causes the common cold 5 years ago, and now it's around again, and we get that cold again. That's because we probably lost our memory for it. This is a new coronavirus, and how coronavirus mutations take place. It's easy for coronaviruses to actually jump from species to species because of its mutations. So that's coronavirus was responsible for the SARS outbreak, which we experienced in this country several years ago. And that was from a bird because it changes enough that the surface proteins of the virus don't always just attach to birds, but could attach to humans instead. And so that's the theory behind the development of the coronavirus, is that in an open air market where lots of animals were together, animals that typically carry coronavirus could have mutated to jump species, and it's a brand new one and quickly infects a lot of people. And the dangerous part of coronavirus is that it has a very long incubation period, sometimes up to 14 days, which means I could not have symptoms but be infecting everybody around me, which is of course the problem. So as we all are aware, there's many different presentations of the coronavirus. Some are much mild, asymptomatic, and some are quite severe. The ones that are severe happen because of the amount of edema that occurs for people in their lungs. So the picture I have for you, that is on, looks like slide 28, is a CT scan of someone who had severe respiratory coronavirus infection. So all those areas that are the paler color are areas of inflammation in the lung parenchyma. which is sometimes referred to as ground glass inflammation. And it can be quite diffuse, which means the person, it's the lung parenchyma, so it's the alveoli, lung lobules, and the supportive tissue of the lungs. Those areas, there'll be less ability for oxygen diffusion because of the increased thickness of the membrane or potential mucus plugging, so the oxygen can't even get there, so decrease in surface area. So these people tend to have a lot of exudate in the alveoli, which will decrease the surface area for diffusion, and fibroplastic plugs are noted in the air spaces. So as the body is healing, there can be lots of plugging of mucus, so they can't get down to do gas exchange. So it can be quite deadly for some people, obviously. The last lecture that will go with the respiratory part of this will be on obstructive versus restrictive lung disorders.